Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Welcome back to the Feeding Pod. I am here today with Stephanie Lamanna, and I'm so excited to have her on. Stephanie is a friend of mine, and after reading her piece that she put in the ASHA Leader on social determinants of health to consider at NICU discharge, I was like, no, we need to talk about this more. We need to talk about this more. So I am really excited about this. I'm going to toss the mic over to Steph to kind of give a quick intro. She is a pediatric feeding therapist and obviously has some insight from the NICU and beyond. So Steph, why don't you give us like a quick intro of who you are, what you do, a little bit about yourself.
Sure. Thanks, Bri. I'm so excited to be here and talk about a topic that is so near and dear to my heart and that I'm passionate about. So I'm Steph Lamanna. I'm an SLP. I'm a certified neonatal therapist. I've been practicing basically across like the entire pediatric service line for the last decade. I've worked in outpatient, inpatient, NICU, ENT clinic. I love fees. I love airways. And right now, currently, I'm lucky enough to be one of the associate directors on the healthcare services team at ASHA. So I'm also getting to, spread my knowledge and create some resources for other pediatric feeding therapists just like me.
Awesome. Yeah, I am so excited to have you here. You are such a treasure to the field. And for those of you that don't know Steph in any capacity, many of you have probably received emails or seen her in like the SIG 13 community threads, she's just an amazing human overall. So I'm so excited to have you here. Okay, so let's like dive into this. I'm really excited, as I said, about this topic. Both Steph and I are very passionate about this, talking about social determinants of health and how this really influences patient care. And we also both agree that this is a super under discussed topic. It's not brought up a lot. I can even think of people who are like, social determinants of health. What does that mean? What does that term even stand for? So why don't you start there? Why don't you kind of give the audience an explanation of like, what are social determinants of health exactly? Like, what does that mean when you use that term?
Sure. That's a really great question. And it brings me back to this time last year. I was helping moderate some of the sessions for ASHA's first healthcare summit. And one of the questions I had asked the presenters was, how do you incorporate a patient's social determinants of health into your plan of care? And they both just stared at me and it was like crickets. And they were like, they're what? And I was, I explained it, of course, and it just really opened my eyes to lots of people don't even know what that means. And it is a big fancy term for things that everyone definitely knows, right? So social determinants of health are basically the circumstances in which we live, we play, we work, we, practice religion that sort of influence our everyday lives. So some of those examples can be the environment in which you live in. It can be your access to education, your access to healthcare. It can include, access to fresh water and clean living. So yeah, our social determinants of health are really those factors that then influence outcomes for us. And social determinants of health are not positive or negative. They're just kind of neutral.
I think the last part you said, it's not necessarily in this like positive or negative light. I'm so glad you brought that up because I think oftentimes social determinants of health are thought of as being a negative light, as if it's a lesser than thing. And while some of them are related to barriers in access, some of them are facilitators, or some of them are what helps our clients. And a lot of them are just things that are neutral either way. However, they can become positives or negatives. So, like benefits or facilitators, depending on how the clinician approaches them and the clinician's awareness of them.
Absolutely, 100%. I think, a good example of this is maybe a family that is, privileged, right? They live in a great town, they have access to lots of resources, they have the financial ability, to access healthcare, and a family member gets into, a really significant accident or something, and they have a brain injury or they have a significant illness. And now they are, even though they have access to all of this stuff, they've lost their job. Maybe they don't have strong community relationships. So even though you think that that person would thrive, whereas maybe someone who is living in a less desirable area or experiences more difficulties financially might have better community support where they're able to overcome some of these barriers.
Yeah, absolutely. And I think that's a good point to bring up as well, is sort of how they can overlap. And it's not all areas that are, barriers to access to care. Some might be a barrier, but if another one is, in a more positive light, like maybe we have the barrier of educational status or, decreased health literacy. But if we live in a neighborhood and have a supportive home environment that can help meet those needs, or we live in a community that has good access to quality health care, then it can kind of offset some of those other barriers. And so it really is like a balance and just figuring that out and knowing the client and the family.
Sure. I think a good example of this is in the article that I wrote for the Leader. We gave this kind of fictional case study that was certainly fictional, but drawn from, my experiences working in the NICU and just things I've come across and families I've worked with. And, you can have a set of young parents who are 18, 19 years old, who maybe don't have that educational piece, don't have that health literacy necessarily because they're so young, but they have a grandmother who is a nurse. And, she's able to help them get to their appointments and understand and, help them understand their baby's medications and help them understand, why their baby needs certain appointments and things like that. So again, they're neither positive nor negative. They just are, but they can create a barrier for some of our patients.
Yeah, definitely. And I think that kind of, your example is going to help sort of segue into this next piece, which is really talking about how do social determinants of health apply to pediatric feeding disorders? And so how do we have a role there, even starting out from birth, right? So thinking about the NICU setting, which is really where kind of like your piece where you were discussing NICU is like, okay, NICU discharge, but some of that really starts in the NICU care. So why don't you shed some light on sort of how these play a role in pediatric feeding?
Sure. Yeah, there's a couple different ways I want to go with this, and I have two thoughts first and foremost. One of the first things I got to do for ASHA when I started working there a year ago was review Cheryl Hirsch's podcast that she did on social determinants of health in pediatric feeding. And there's this one statement she makes that blew my mind. And Bree, you know exactly what I'm going to say. But she talked about how they would make recommendations for children to practice with like meltable crunchies. And these foods weren't even on the SNAP benefits, or as we know them, food stamps, on the benefit list. So they were recommending these foods for families that they couldn't purchase and they couldn't otherwise afford. And that just like blew my mind. I was like, somebody said it out loud, and that's incredible. And I think that's one of the places where we can make the biggest impact in pediatric feeding is understanding, what our patients need, what their access to resources are, how they're able to get them, what other resources do they need, and how can we facilitate that, and how can we just be aware of those barriers. There are so many foods that children can practice with. If you just have a general idea of what's on your state's SNAP benefits eligibility, you can make some recommendations. But if you don't even know that you need to be aware of that, then your family's going to feel like they're the ones who are failing when really it's us putting them in a situation that's more challenging for them.
Yeah, I agree with that. And I think just like even within that, as you learn more and more about this and learn more and more about the resources that are available to families and the, restrictions that may be there, I have found, for example, families that are using SNAP through WIC, the Women, Infant, and Children program. It is one of those things that at 12 months old, they no longer get access to baby foods like purees and, those things are taken off the list. And so in this situation, if you have a child who's 12 months old, 13 months old, 14 months old, who is still on purees because of an oral dysphagia, now the family can't afford those types of foods. And so, yes, that we can do some education on like home blending and working on that. But there are also resources to be aware of where you can get a script written to extend their coverage past 12 months old. So there are resources around that, but a lot of it just takes, us as the clinicians taking the time to recognize that's there and then helping the family advocate for those modifications. And really it starts with exactly what you said, like just being aware of these barriers.
I think one of the other things is, and this brings in cultural responsiveness as well, right? And I can give you a really good example of this. I'm lucky enough to still be able to work clinically, and I work in a level 3 NICU in a community hospital. And in this hospital, we are in a predominantly white, predominantly upper middle class neighborhood. So that's, sort of the patients that we get. And a lot of our staff has worked at this hospital for their entire careers. It's a really nice hospital to work at. Why wouldn't you want to stay there, right? And our hospital system a couple of years ago merged with another hospital system that has a smaller NICU in an underserved community. And we now get a lot of those transfers of those smaller and sicker babies to our unit. And some of the reactions from staff in terms of the barriers that these families are facing at discharge was shocking to me. Like, I've worked in a lot of different communities, and, some of these people who have never experienced what it's like for patients to have barriers, and the way that their biases just came through was really shocking, and they would get frustrated. Like, what do you mean they don't have access to this bottle? What do you mean that they can't get this type of formula? What do you mean the parent doesn't know how to read the directions on the formula, and we need to, create a visual for them? And I feel like as SLPs, we think about that stuff a lot of the time, but it gives us an opportunity to take it a step further for our patients and kind of almost anticipating their barriers and helping them work through it.
Mm-hmm. Yeah, definitely. And I think that also is where we play a role in like advocacy and educating other providers as well. I think the NICU is a big one where, and I've never worked in the NICU, but this is, thinking about talking with colleagues that do. And one of the big ones is oh, they never visit their baby. They just don't care. They never come here to visit. They're never here for feedings, and it's like, this baby was born premature. They don't have, maybe good maternity leave. Maybe it's a very short maternity leave. And so they prefer to hold on until their baby's home to be able to use that leave. Like there's just so many implications there. Or if they don't work, they lose the insurance to pay for the medical treatment so that their child can receive better services in the end. And like I feel like that's a big one. And that's one that I've seen in the home health and outpatient setting as well, specifically in the outpatient setting, when you have a client who has difficulties with transportation and, they are relying on the Medicaid service to pick them up, which they have to schedule ahead of time, which is a whole process in and of itself. And then Medicaid will drop them off at their appointment and be like, all right, see you in 3 hours. And they're like, the appointment's only 45 minutes. It's like, well, we have to do a couple other things. So you now have to be here for 3 hours. And they don't have 3 hours to take off work. They don't have 3 hours of childcare for their other children. And it's like, we forget that like maybe that's why they're not coming to therapy except for once a month, because that's all they can afford to do because of that example. But then it goes into the implicit bias and the prejudices that then occur in prejudging people without fully actually understanding their situation and bridging that gap and supporting them in that manner.
We had a situation one time in my NICU where we had a smaller baby who was getting ready to eat for the first time. And we always try to A, have the first feedings at the breast, B, have the parents present if, regardless of whether the baby was breast or bottle feeding, and have it be kind of like a joint effort between speech, parents, nursing, everyone working together, IBCLC, if the parent was breastfeeding or chest feeding. And this particular family couldn't come in because they had barriers related to transportation. They didn't have a car. One of the parents borrowed a car from a family and was able to get back and forth to work with that. They didn't really necessarily qualify for transportation assistance. And I remember talking at rounds and everyone was like, well, like, why don't we just have speech feed the baby for the first time? Like, this mom's not giving breast milk, like the baby's getting formula, so like it really doesn't matter. And I was like, wait, everyone, hold on a second. And it took me a long time to get comfortable speaking up in these situations. And I think that's fair to mention, right? Like, this was a couple of years into my career. I was comfortable with these people. So it's not always easy for the first time, right? But at this point, I was kind of like, there's got to be something better we can do here for this family. And one of the things that I mentioned in my article about a tangible resource you could just like kind of take back to your hospital or whatever setting you're in is reaching out to your hospital's charitable foundation. Most hospitals will have one, even your small community hospitals. My hospital is not that big. We still have a very prolific charitable foundation. So we went to them and we got a couple of rideshare gift cards. So parent was able to come in during the day, and we set up, this was pre-pandemic, unfortunately, but we set up child life with the older sibling, and we had this mom bottle feed her baby for the first time. And it took a little bit of work, to get through some of these barriers, but it worked out, and it worked out really well. And honestly, like, it wasn't really that hard to do. So I think just recognizing, where these sort of factors are and how you can bring them to others' attention, right? As an SLP, we're not responsible for solving every single barrier for our patients. We just can't. A, it's not necessarily, our responsibility to do so. And B, we don't always have all the resources to do that on our own. But by bringing them to others' attention, we are able to get the entire team on board to help.
Definitely. And I think that like doing something like that, where it's like, yes, this took me a little bit more time and a little bit more effort, not excessively. I just had to really draw attention to the factor. But by doing so, you probably strengthened your rapport and trust with the family so much more than had you said, hey, your child had their first feeding. Here's how it went. We'll talk to you about it when you come in. That would have lost trust. And, especially after COVID, with the levels of mistrust that are in place with healthcare, we need to pay even closer attention to how we are building trust with the families that we're working with. And small things like that, like waiting 6, 12, 24 more hours before 48 more hours before you do that first feeding so that the family can be there, can be so powerful. And so I think that, really, really is a testament to facilitating a potential social determinant of health barrier. And so I think that's a great point to make. Okay, I wanted to talk a little bit about, so we think about social determinants of health. I kind of wanted to go through, and this is going to be my like rapid fire question round for you. And then I want to talk about some more case examples. However, what I want to do for this is something that I just do randomly when I remember to, if I'm being honest. I would like to do a rapid fire round with everyone, but sometimes I forget. So your rapid fire round is where I'm going to basically just fire a question at you. And I want you to answer in just like a couple words or a sentence in what kind of comes to mind. Okay. All right. So in regards to social determinants of health, if we're thinking about education, access, and quality, what is the first thing that comes to mind for you in a way you can support families who may have decreased educational status or health literacy?
Asking them how they prefer to receive information.
Oh, I love that. And I feel like that's just that in of itself is like, you're just like, how do you prefer information? It's not like, what's your level of education? There's no judgment in it at all. It's just, how do you prefer to learn? I think that's a great way to answer it. Okay. Next question. What is something that you have implemented with like your patients or your families in your assessment or treatment approach to learn more about a patient's social determinants of health status?
Ooh, really good question. So I will often ask them how difficult scheduling is for them. And that's sort of like a neutral question that can give me a little bit more information
Yeah.
about what's going on in their lives. And then I can sort of probe a little bit further. If
Mhm.
scheduling is really challenging, that kind of opens the door to asking other questions about transportation, what their family life is like, and what things are like at home.
Mhm. I think that's a great question too, from a culturally responsive lens, in terms of just like how do they view the importance of appointments, timeliness, working around different like prayer times, or, maybe they have church things on Wednesdays. And so, I think that opens up even more to that conversation as well. I love that. So, next one that I have for you is, what is something you've learned about client food choices or food access through your practice? And how has that maybe modified the way you approach making selections about food moving forward?
Ooh, well, I think one of the bigger things that I've learned, over the last like very few recent years is that I need to check my understanding of what food choices are and not impose that upon my clients or
Mhm,
patients.
mhm. Yeah, I think that's big. I think food is, and when we think about pediatric feeding disorders, like there's a psychosocial domain for a reason. It's not just for nourishment. There's a lot of other factors that go into play there. So I
Yeah.
love that answer.
I also will ask parents. I used to always buy food for clinic, and I still do, just to have stuff in case like a parent forgets or they can't get access. But when I'm walking down, the grocery aisles, I'm picking out what I like. And even though I try to think about it, to have a lot of variety, I can't anticipate every single patient or family's preferences, right? So I always ask them if they're able to bring their own food so we have access to their preferences.
Mhm, mhm.
Now, that's not always reasonable and something that every parent can do, but I always give them the option and ask them how I can support them in doing so.
Yeah, I think that going off of family and client specific food choices that are relevant to like what they're eating at home, what's most accessible, is also a great way to like support carryover and generalization of your recommendations. Because if they don't have access to the thing you're recommending, then it really isn't necessarily going to help anything. Okay, the last question is, who who do you feel like in your, or not necessarily who, but who or what, or is there a resource or a person where you would suggest people go to learn more about social determinants of health?
I'm going to give a little plug for my team here. And I'm going to say that check out ASHA's resources on social determinants of health. So we don't have, a plethora of resources just yet, but we're starting to build them up, and it's a huge priority for our team this year. So you can look at our website, which includes some of that information. And Brie, can you drop a link somewhere for that?
Yeah, it'll be in the show notes. I'll have the
Okay,
link to all of
perfect.
the things we've talked about today, including that podcast episode with Cheryl Hirsch, which was also very excellent. I really
Perfect.
appreciated that as well. And I'll drop a couple other links that talk about just some resources, some articles that talk about these impacts. And one of them would be Feeding Matters had like an economic impact report that came out, and that can really fluctuate into there. So yeah, awesome.
I think
Okay.
that's perfect. Healthy Children 2030
Yep.
is also a really great, or is it Healthy Children or Healthy Families, whatever
Yeah.
it
Healthy
is.
children. I think it's Healthy Children 2030.
Yeah.
Now I
Let
gotta
me
look it
Google
up.
it.
Yep. Maybe it is
Uh,
families, but I thought it was healthy children.
I thought it was
Healthy
healthy.
people.
Healthy people. Okay.
People.
Perfect. Okay.
Everybody.
All
Healthy
right.
people 2030.
Yes. So Healthy People 2030 is the US Department of Health and Human Services website that talks about social determinants of health. So you can learn a lot there.
Yes, definitely. And I think so much of this is literally starting out with just learning about it. Because like Steph said, like she asked a question one time, someone was like, I don't even know what you mean by social determinants of health. And once you learn what it is, you realize, oh, this is like literally your day-to-day living and what affects you accessing healthcare, from where you work, where you have fun, where you live, like all of these aspects. So you probably know more about it than you realize. And hopefully you're starting to reflect on some of these things and like, oh, that happened in my practice. But definitely just start with learning about it. Start with learning the term and becoming familiar with those barriers and facilitators. Okay, so we're going to transition into this last part where I would love for you to share, and of course I'll do my own little reflection on case examples of where we might see this into play. So why don't we start with your case example talking about thickeners? I am really excited to see how this plays a role. I kind of know how it plays a role, but I want you to explain how it plays a role to the listeners.
Yeah. So thickening, the bane of our existence. This is a really great question. And I don't have a specific case example in terms of like this happened, but I have a couple different thoughts and like what I can pull from my patient experience. So
more so how it can apply to like other people's cases.
Yeah, exactly. Yeah.
Mm-hmm.
So thickeners are really challenging for a number of reasons, right? We know that the literature is very mixed on thickening. There's a lot, especially coming out in the adult population, about how thickeners affect not only quality of life, but they affect nutrition and hydration, and they're, more likely to be silently aspirated. And, we know that thickening is not always the way as, maybe it was 3, 5, 10 years ago. So that being said, we do know it is important sometimes for some of our patients. And one of the things we do in the clinic where I work is we will sometimes thicken to manage reflux symptoms for babies who are having really, really severe reflux. So with thickening comes this risk benefit analysis all the time. And in this context, I'm not just talking about clinically. I think we need to look at it from the perspective of the family. A couple different things. We know that rice cereal is like off the table now because of the arsenic risk. Oatmeal cereal is not great for nutrition and constipation and all of that. And it adds a lot of really empty calories for very little nutritional value. For commercial thickeners, gel mix, any of those are expensive. They're what now almost $30 a can.
And it's so hard to get insurance coverage on them.
I've never had success with an insurance company covering gel mix.
Yeah, it's so difficult.
So for our families who, may have benefits through their work, if they can afford to have an FSA, the FSA, can cover it, but not many of our patients or families have that. And there's a lot of really great resources out there in terms of helping families get access to thickeners. Dysphagia Outreach Project, helps families with that. Bree, do you know of any others?
I mean, we have one locally in the upstate, the Pediatric Feeding Disorders Foundation,
Yep.
but it's going to be like it's specific to a local community. So, being able to, I think, be more familiar with not just like dysphagia outreach project that's nationwide, but also like recognizing there may be local resources to help with it. But again, like the process of going through those and submitting the paperwork and getting all the things signed and all of that, like to justify why you need the funding for an item or why you need the thickener can also be a barrier for a lot of families
The
in
biggest
getting that
question is,
access.
can your families read the paperwork that
Right.
they need? Do they have internet access
Right. Can they
to
access the
even
website to even apply?
right, exactly.
Mhm.
And I think even for families who may have the financial means, right? Because we can't draw these parallels between health literacy, educational access, and financial access, right? Or financial stability. Like they're not all congruent. But your patient may have the financial needs to be able to pay for, gel mix, a 1 can a month or something like that. But do they have the educational understanding of what it is? Can they access buying it online? Yeah, it's on Amazon. We think of Amazon being super easy, right? But is it easy for them? Do they know how to read the instructions on the can? Are they sure they're buying the right product? Like that's another big thing. So it's not just the financial access to it. It's all the other pieces that we have to consider. Thickening isn't just a clinical recommendation. And you want to weigh that against your patient's individual contextual factors, that contribute to do they need this thickener or not.
And I think, it's like what we've kind of come through to and like what this, the conclusion of this is like it's not even just a question of whether to thicken or not. It's also a question of like what thickener choice do you make? And, maybe the family can afford some commercial thickener and the rest of the time you're also using food-based thickeners because that's what's accessible, that's what they have available. And so you're not just looking at it, like you said, from the clinical lens of like safety, contraindications, amount, all of those risks. You're also thinking about like, is this even accessible and affordable to this family? Because if it's not, they could want to do it as much as they, can, but they can't afford it. Or because they're having to do this thickener, they can't come to as many therapy visits because they can't afford the transportation there now because they're having to pay for like there's so many layers to those singular decisions. And so it's really important to think about that when we're making those recommendations. But then, like you said, just like using the resources we can when they are available to help offset some of that.
And I love what you brought up about using a commercial thickener part of the time and food-based thickener, other parts of the time. And I think, if you kind of even break it down further than that, like you have to even consider, can your patients follow directions for two different things? Food-based thickeners are not cheap. I don't know if you've bought Gerber baby food lately, but I have, and it is expensive. These costs add up. And even for the families who don't have any financial difficulties or are able to afford some of this stuff, those costs add up when you add in copays, when you add in other supplies. We're most likely not the only service that a child needs, especially if we're talking about our post NICU population. Copays for other visits and costs of travel, it all adds up. You're absolutely right that thickening is not just a singular clinical decision.
Yeah. And I think to your point about like food-based thickeners being more expensive, like having, I mean, all of it has expenses, right? All of it is in addition to what the family was expecting potentially to have to afford, right? Just in terms of like the food and liquids they expected to buy for their child. Now they're having to buy extra in order to, support their child's oral pharyngeal dysphagia status. And there's a quote from an article by Okada and colleagues that came out in 2022. And they also talked about how a commonly reported barrier and I'm quoting this directly. So commonly reported barriers to using assistive programs included desire for self-reliance, lack of knowledge or worry regarding paperwork, stigma, and concern over ineligibility. So these families who are having trouble affording a food-based thickener, which can be covered by WIC through the SNAPS program, might not even do the program because they are afraid of completing the paperwork, of being reliant on some type of support system because of this stigma or feeling about it. And so, it can also be easy for us to be like, well, just go do this thing. You can get SNAPs, you can get coverage. And there might be cultural factors there that are preventing them from seeking outside help. And so sometimes it also is like bridging that piece. And so it's like, yes, we're sitting here saying like those things are expensive, and they are. And if a family can't afford them, they might not even want to seek the resource to be able to. And then that's a whole nother, layer that you kind of have to work through.
I think it also, kind of blends us into the point of the mental health impact that a pediatric feeding disorder has on a family. And I think a really good example of this is a patient that I saw yesterday, baby girl born at 34 weeks gestation. And she, had a little bit of a rougher course than most babies born at that age typically do. And she ended up leaving the hospital with an NG tube. And our feeling was that she just needed a little bit more support for a little bit, longer period of time, that she eventually was going to be okay. And there were a couple weeks that lapsed in between when she left the NICU and when she came in for her follow-up appointment, and her tube was out and she was eating great and she was doing really well, just like we had expected. But she was still a little lower tone than I'd like to see for that age. So I talked to her parents about making an early intervention referral, right? And like, we look at early intervention as so benign, like, right?
We look at it like everyone should get it. We're like, early intervention is great for everybody.
Yeah. And in the state of New Jersey, I'm just not sure. I don't primarily work in early intervention, so I can't speak to, what the eligibility requirement is in other states, but in New Jersey, they don't correct for prematurity. So everyone qualifies, which is really, or at least all preterm infants will qualify, because they're always going to be behind when you compare them to their actual age. So that being said, I'm kind of explaining this to the parents, and they're like stopping making eye contact with me. And they're like, you know what? Like, we kind of really want to hold off on that. And in the moment, I was perplexed because I was like, okay, like, I was picking up what they were dropping off. So, I kind of said to them, like, all right, like, we have a follow-up appointment in 2 weeks to check on you guys again. Why don't we see where we're at that point, and we'll kind of discuss it. And they were like, yeah, you know what? That sounds great. And after they left, I kind of thought about it a little bit more, and it made me really think about, what did they experience in their NICU stay and then after discharge, where their entire understanding of what a normal pregnancy is, what they were expecting for birth, was completely shattered. Their baby was in the NICU for 6 weeks. The interprofessional team comes in and tells them that their baby needs to go home with a temporary feeding tube. And even though we're telling them that, I think your baby's only going to need this for a couple of weeks, they just need a little bit more time, they're going to be totally fine, they stopped listening after they heard your baby needs a feeding tube, right? So they take their baby home, they're petrified of managing this thing. Even though we've trained them, they're terrified of managing it. And then they finally get past that. And then somebody with all the really great intention in the world is saying, you know what? I think your baby needs some more help. Like, what does that do to that family? So even when we're, bringing up like, oh, you can access this resource and, go get SNAP benefits and this and that, and they'll cover this and they'll pay for this, parents stop listening. And all they're thinking about is the mountain that they're at the bottom of, and how overwhelmed they are by all the barriers that they face that they're not even aware of. And that they can't even begin to think about overcoming because they don't even know what they are.
Yeah, absolutely. I think that's such a good point to bring up, because there is a level of prioritization we have to put on when providing resources. We've talked about this before, but like even with referrals, when we're like, oh, you should go see this person, or, in my head, but sometimes the family cannot handle discussing all of those referrals at once. And you need to be able to say, like, what's a priority. And I'm, reflecting just on the case you just talked about. And I'm thinking, like, what if this was a family that was like they were feeling, right? Like, all right, we've overcome this barrier. Like, she's doing well. Hopefully we're going to get back to work soon. Things are going to be just great. And it's like, again, totally well intended, right? I would have done the same thing. I would have been like, maybe we should talk about getting you. Because in our head, we're thinking, all right, it can take a couple weeks to get this established. You got to get the referral, and you're going to have to go through that initial eval before you can even see the specialist. And like, we're going through all of that thinking, like, let's get ahead of it without, and then it's like, oh, wait a minute. And I think you bringing that up also shows how this is just like, I feel like learning about this aligns really well with cultural competency, and that it is an ongoing process. It is lifelong. It requires a lot of self-reflection, a lot of getting uncomfortable with, like, what did I do? How could I have done that better? What were the cues they showed? How am I going to approach that in another situation, in another light? And so I think, I'm so glad that you were vulnerable and shared that, like, that learning experience, that you're like, yeah, and this happened like literally yesterday. And it's like, those will continue to happen, and they're supposed to happen. And so I think that that's just such a good point too, to go back to, like, that self-reflection piece and how important that is to learning about this and bettering patient care. So, okay. One more topic to talk about, and this is one that I know gets both of us really heated. So thinking about, like, just inequities to certain care, thinking about ableism that's built in our systems, thinking about how we can support, clients in accessing quality healthcare when so many are quick to be cash pay only, not offer, certain services to certain people strictly because of the inequities that are present.
Yeah. So this is a really great, sort of question. And I particularly feel strongly about this because I am, again, practicing in an area that is predominantly wealthy, predominantly, white, middle to upper class families with a lot of access to resources and a lot of financial stability. And one of the things that's frustrating about the area that I practice in is that there is such a dearth of services, and especially a dearth of services for providers who accept Medicare, Medicaid, or Medicaid.
I feel like
There,
I'm sorry to interrupt you. I just feel like it like feeds the very problem we're trying to facilitate not being such a barrier, right? Like, we're sitting here talking about how people have decreased access to quality healthcare, and by having a scarcity of providers who are willing to accept those programs. And I empathize with providers because reimbursement from insurance is so poor. And I know, like, it's very state by state, but I know I can speak for South Carolina, and that the reimbursement rate for pediatric feeding is horrific for Medicaid in comparison to many other states, but there is also the same across the board, right? And so I absolutely empathize with that piece. However, there's also sort of, in my opinion, this is me strictly speaking from my opinion, there's an ethical dilemma that we kind of have to play with here in recognizing where, by doing things that are like cash pay only services, by doing something like that, you are, if the service you're providing is so absolutely medically necessary to these clients, then, why are you only giving access to those that can afford it?
Sure. No, I think that's a great point. And, there's a couple different sides to that, right? So the first, sort of side to that is your provider who, leaves a established health system to provide services on their own. And I will tell you, when I started working at the otolaryngology practice I work at, somebody whose job it is, they get paid to credential me with insurance, like did my entire credentialing process, and I never had to worry about it. But it's really challenging and it's really difficult, and they almost make it like counterintuitively hard so you
Yeah,
don't sign up, right?
they do. They do. They make it
So
so, and then it takes like 9 months to do. So like
right.
there is a
And you got
level
to do
where
it
like,
every year.
yep, yep. And so
Mhm.
there is a level of like, yeah, this is going to take some effort for
Yep.
sure.
So I think to have this conversation, we need to recognize part of that, right? And that exists within the sphere of what we're discussing. The second part about this is, for anyone who has questions about, reimbursement related things, I'm going to give a little plug for our stellar reimbursement team at ASHA. And you can email them at any time at reimbursement@asha.org, and they're outstanding and will answer your question, very, very competently and very thoroughly. And, recently they talked to our healthcare team, and the other day, now I'm only speaking about this from the understanding that I have. So, if you want to know more about this, I encourage you to reach out to our reimbursement team. But, what I can comment on a little bit is that, they talked us through some scenarios and how they respond to questions from members. And one of the things they talked about was how if you're charging for services and your service is aligned with the CPT code, you can't overcharge for it because of patients have a right to submit bills to their insurance company for payment. So if you're charging like, $1,000 for a swallow therapy session, somebody might come looking for you. Now, I don't know all the context of what that occurs, what the regulations are. Is it just Medicare? Is it Medicaid?
There's that vagueness of like what's excessive, what's not,
Right.
Mhm.
But I'm, purely just saying that there's this entire reimbursement piece that you need to understand, even if you don't accept insurance. Okay. So there's that piece of it where you need to be aware of like, are you following your state's regulations? Are you doing this? Are you doing that? So access your colleagues, and especially our ASHA team, who has expertise in the reimbursement sphere. We the other part of this is that we need to be really judicious in what we're recommending for our patients, and we can't just blindly make recommendations about, you need to see this person, you need to go here, you need to do this, because we're not keeping in mind their social determinants of health, and we're blindly making recommendations instead of considering a patient or their family's unique contextual factors. So when we're considering their access to transportation, their access to ability to afford these things, their understanding of it and why their child needs it, we need to provide it in a way that they can understand it. And we need to provide it in a way that makes sense to them. And we need to help them achieve access in a way that's functional and respective of their needs and what they want for their family and their child. And we need to be really careful about the language that we use, because families do trust us. You brought up before that there's a lot of distrust in the medical community. And I do have to say that I'm really fortunate in my practice that I just make really great relationships with my families. They trust me from the get-go. And I'm just really fortunate and privileged to experience that. But I have to think really carefully about how I say things to families, because when you're saying your child needs this, that your child will fail without this, your families are going to take that as like the word. And they're going to follow that, and they're going to do what you tell them to do, regardless of if it's something that's accessible for them. And is it really in that family's best interest and in that child's best interest?
Yeah, I think that's a great point, and especially with, unfortunately seeing some of these providers and things that just like refer around in this big circle of like cash pay, and a family, like you said, they truly do want to do what's best for their child. And if you are telling them this is the thing you need to do, this is what you're supposed to do, then they're going to do it. And so I think you bringing up the fact of like just doing your like doing justice to the situation, making sure we are not over pathologizing, over servicing a client for, and focusing more on like functional outcomes and what is like effective and important to that family and that child, because your optimum or like your recommendation, what you truly feel is best or right, might not be for that family. Because if going through with that service requires mom and dad or grandma or whoever the caregiver is to work extra hours, and they don't get to spend as much time with their child, or it requires them to, XYZ, fill in the blank, right? If it is requiring them to take out, get a new credit card, I've literally seen providers make recommendations, and that actually like kind of makes me sick. But they're just like, oh, we have this like medical credit card that you can use to pay for these services. And now that's another debt that they owe. That's not considering social determinants of health. That's not being culturally responsive. And that, is not providing well-informed care to your clients. And so I think that, yeah, that's just like very good reflection to recognize, like, even the things that we think are, maybe it truly is like, we really do feel that you need this. You need to make sure you're finding a way that supports the family where they're at then, before moving forward with those types of recommendations, because it may impact them in a way that you never even really thought that it could.
I think it devalues our profession a little bit too, right? When we're, saying you need this, you need that, you need to see these 6 different providers or however many different providers, and then none of it works. Or the family is not understanding the information that they're getting at all of these appointments because, right, like all the other providers are overworked and tired and maybe not spending as much time with them. So they don't understand. Because they're not getting information in a way that's understandable for them.
Yeah.
Because of that, then, there's maybe not as much follow through, not by any fault of their own, but because they're not receiving information in a way that they can understand it.
Or they're receiving just way too much
information.
Like there's just way too many cooks in the kitchen, where it's like, I can't do the recommendation from all of these providers at once. Like that's just too much. So then you get no carryover.
Mm-hmm. Yep. And then they're frustrated, they're tired, they're burnout, their child is still not eating well, and they're exasperated and they feel like a failure of a parent. And then they don't see value in us or any of the other providers on their care team because they're not getting the help in a way that's accessible for them.
Or the even worse factor of that, I would rather a family feel like I wasn't doing good enough than the fact that sometimes what happens is then they feel that they're not doing enough. They feel like they are responsible for their child not making progress. Well, if you went to more appointments, if you saw the person I told you to, if you carried over with the services, rather than saying, why are they having trouble carrying over the services I'm providing? Is this too much? Am I not providing it in an accessible manner? Is this, what culturally linguistic barriers are present that I need to recognize? And so I think that's the other side of it. Is like, then sometimes these families are quite literally gaslighted into thinking it's their fault that their child didn't make progress, for maybe because they said, hey, I'm not going to go see all of those other people because that's not going to work for me. And then they have the provider who says, well, then we'll keep trying, but we're probably not going to make progress. And I told you why. It's because you had to see. And it's like, when really, as the feeding therapist, as a clinician, we should be reflecting on what we need to change. Because odds are you probably don't need 100 other cooks in the kitchen. There may be a select few. I'm all for interdisciplinary care. It should not be siloed, but we need to prioritize and recognize who we're adding to that group, to that team, and why, and what it is that they're bringing to the team. So
100%. I think you said it beautifully and, really kind of wrapped it all together there. And, I just like to add that Dr. Joan Arvidsson says more is not always better.
Yes. And isn't that not the truth? It is the truth. It is the truth. There is a video actually on YouTube, and I am going to put this in the show notes, and I apologize in advance because the video kind of is never ending, but it's called Too Many Cooks. Have you ever seen it? It's from like a
No.
comedy. It's from like, oh, what is that late night comedy? Hold on. I'm gonna find.
Saturday Night Live.
No, it's so funny. Hold on. It it literally is just like this from Adult Swim. So Too Many
Oh,
Cooks from Adult Swim is this music video that literally just like it never ends and it just says too many cooks, too many cooks. And I feel like that's how it feels sometimes when there is literally just too many providers, doing too many different things that don't overlap in the way they're supposed to do. So I'm going to put it in there and people should go watch it and you'll know how these families feel.
I love it. It's such a good point. It is
Yeah.
such a good point.
Because it is true. Sometimes it's more is not always better. More is not always better. So, all right. Well, thank you so much, Steph. I appreciate you immensely. I think this was just such a valuable talk. We could both talk about this for about 10 more hours easily.
Easily.
But we're gonna stop there. We're gonna stop there. Is there any other closing thoughts that you have, or where can people find you or learn a little bit more? Of course, in the show notes, I'm gonna put your article down so that they can read about it. But if people have more questions or just want to reach out, how can they find you?
Yeah, great question. Bree, I'll give you my email address so you can drop it in the show notes, and feel free
Perfect.
to email me at any time if you just want to comment, or you want me to know something, or you want to pick my brain. I'm happy to share. And I think just, to kind of end this up is, or, wrap this up is just, really think critically about, all different parts of your patients. Take this holistic view of all the pieces of their care. And again, like Dr. Joan Arvidson says, always think about what else, you could be missing. And when you step back and look at the big picture, there's so much more we can help families overcome, even if it feels like it's a lot for them.
Yeah, absolutely. Awesome. Well, thank you so much. I'm looking forward to this episode coming out. This was a good time.
Woo! Thank you so much for having me. I love this. Let's do it again.
Yeah. Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.